So welcome everybody and good afternoon. Thank you for attending this webinar co-organized by EURO-NMD in partnership with European Academy of Neurology and ERN R&D for rare neurological diseases. For today's episode, one of the last episode of the Neuropathology webinar series, we welcome back Professor Edoardo Malfatti. So a little presentation of Edoardo Malfatti. He's a clinical scientist specializing in neuromuscular disorders with over 15 years of experience across Italy, France, and Sweden. He leads a research group at INSERM focusing on gene therapies and drug repurposing for myopathies. So thank you very much again, Edoardo Malfatti, for leading this webinar, and the floor is yours.
Thank you very much, Elizabeth. Hello, everybody. So today I will cover novel approaches and future developments in neuromuscular pathology. These are my disclosure, and I will focus on myopathology, talking first about digital myopathology and its application in diagnosis and quantification of different type of fibers. I will then introduce a little bit the concept of artificial intelligence and how we can apply these combined to digital pathology to myopathology. I will describe a project that we have ongoing of a characterization of a pathological lesion in calpainopathies linked to calpain 3 deficiency. I will go briefly into skeletal muscle spatial transcriptomic as a research approach made on this section cut from muscle biopsy. Just a brief description of new interesting finding about a protein that is involved in a limb-girdle muscular dystrophy that has been characterized with cryo-electron microscopy, and then I will go into conclusion and perspective. So just to remind you that when we do a muscle biopsy, we have many opportunities, both from a diagnostic point of view with light microscopy technique, electron microscopy technique. We have the possibility to extract DNA or RNA from the tissue, and we have now possibility to do multi-omics approach like a single nuclei sequencing, RNA sequencing, or single cell RNA sequencing, and spatial transcriptomics directly on the tissue. Furthermore, we can do protein studies, and the culture of primary myoblasts is very important for research purposes in order to validate, for example, variants that has been found by next generation sequencing. The digital pathology is already here. It consists in scanning through a scanner of slides the section that has been stained with the different techniques. And these allow you a global vision of the section. This is widely used in the general pathology lab, and also it will arrive to our bench. In our unit, we already have a scanner, and we select a specific case in order to do digital pathology for the muscle biopsies analysis. One of the main points of digital pathology is the availability of a big server and area where we can stock the huge quantity of images that we produce with this kind of technique. And the result of a scan, here you have an H&E section of a patient with necrotizing autoimmune myopathies. You can see that we can see very well the different sections. We can zoom in, we can have an appreciation of the different techniques, and then we can have an easier evaluation of muscle biopsy sample for classifying and diagnosis muscle disease. So this technique is under implementation in different centers, and I think we can all benefit of this. But of course, when we have a muscle biopsy and scan imaging, we need to identify the different lesions. And here I would like to mention an initiative that was promoted by Norma Romero at the Myology Institute, where the first muscle atlas that collect database of muscle images designed to facilitate research, diagnosis, and knowledge in the field of neuromuscular pathology has been created. To date, there are more than 6,400 images in this database, and this is easily and freely accessible, and will help you, if you need it, to search for specific lesion and to help you in making a diagnosis of your muscle biopsy. In terms of quantification and recognition of the lesion based on digital pathologies approaches, one important element that we analyze, for example, with ATPases techniques, when we do a diagnosis on a muscle biopsy, is the quantification and the diameter of type 1 or type 2 fibers and the subgroup of type 2 fibers. In order to do this, different efforts have been done, and one that was coordinated by Teresina Evangelista was a comprehensive morphometric assessment of the deltoid muscle development in children. This is a cross-sectional study where three groups of different muscle biopsy, including in the first group, biopsy taken between 0 to 24 months, the second group 25 months to 10 years, 11 years to 18 years have been analyzed using this Carpaccio cloud algorithm that, as you can see here, allow the segmentation and the identification of the boundaries of the fibers, and also the difference between type 1 and type 2 fibers. The researchers in this study demonstrate that there is an evolution of different morphometric parameters according to the different fiber size, and this happened from birth to the age of 18 in both females and males, and they establish the normative values that can be used, for example, in your routine to assess the characteristic of muscle fibers type in this age range when you perform a diagnosis. The main limitation of the study is the relative low number of muscle biopsy that were analyzed. But as you know, when we do a muscle biopsy, we need to have a clinical hint. It's not ethical to perform muscle biopsy to the population that do not present health problems. Another approach, similar but different in the way the type 1 and type 2 muscle fibers has been analyzed. This is immunofluorescence using protein of the sarcolemma or the cytoskeleton like dystrophin and myosin heavy chain, and thanks to a segmentation mask, the author here in our institute could develop an automated image analysis that allowed to quantify the fiber morphometry, so to measure the diameter, to determine the different composition of muscle in terms of different population. And this is particularly interesting because there was an analysis in adult muscle, and so we can also extrapolate information about the evolution and the different distribution of the muscle with age and in conditions that are related to age, like sarcopenia. These two approaches of digital pathology did not really use what we call the artificial intelligence, where for artificial intelligence we consider the definition is that all the systems that are designed by humans that mimics cognitive function, which given a specific background and a specific objective can lead to the best way to arrive to the aim initially proposed. So thanks to a learning that can be machine learning, deep learning, or convolutional neural network, we can get any information from the artificial intelligence, compare it, for example, with the interpretation that is done by an investigator. Deep learning is a technology applied to artificial intelligence. It is used for specific tasks. It helps, for example, analyzing medical and pathological images, comparing it to human expert. And deep learning methods are basically the representation learning methods that utilize multiple levels of representation that are obtained by composing single but not linear models that each transform the representation at one level, starting with the raw input into representation at higher, slightly more abstract level. And here I put an example of a review article that really explain you the different methods, included deep learning. The application of artificial intelligence of neuromuscular disease is very interesting for us because thanks to this application, we can develop and apply different diagnostic algorithms. We can perform, for example, a follow-up and quantify how the lesion have been changed. And in neuromuscular disorder, it has been already applied widely, the artificial intelligence to muscle imaging, for example, muscle MRI, to the detection of biomarkers, to electromyography. But what about myopathology? So the first studies date back to 2018, and in these studies, this is the first that I want to mention to you. The authors created using a mouse model a specific mask of muscle J that allow to quantify and calculate the presence of different parameters. The different parameters are listed here. The authors took muscle from mice, tibialis anterior and gastrocnemius, between 7 and to 11 weeks that were injured with cardiotoxin. And then in every sample, they applied the muscle J mask and submitted the images to the expert in order to quantify, for example, the fiber nucleus, the satellite cell, the vessel, or the fiber types. With the validation, the authors demonstrated that the muscle J was, for example, a little bit less superior, a little bit below the level of recognition of the expert, but in other field, for example, the satellite recognition, this was more efficient. For the vessel, this was particularly true, and also for the fiber type, specifically for the type 2X and 2B. So again, a mask that is called muscle J that utilizing the immunofluorescence help to quantify automatically features that are important to quantify, for example, in mouse model in order to develop, for example, therapeutic strategy. In OpenExam, that is a tool for semi-automatic analysis for myofiber cross-sectional areas in regenerating adult muscle, the authors also used different mouse models. Wild-type muscle that were injured compared to dystrophic mice where they took tibialis anterior. The images were observed, and what they did, they compare different two in order to quantify the cross-sectional area. And for example, they compare also with the muscle J that I showed you before. And what they found is that this OpenSum, it's with the semi-automated analysis, is more accurate, for example, in measure the cross-sectional area in regenerating and dystrophic muscle compared to classical segmentation tool. Another software is Myosoft that utilize algorithm developed with Fiji ImageJ software. And in this case, the analysis is done using machine learning. And the background is that usually the traditional segmentation are successful only when the image have a high signal and noise ratio and image feature are simple. In Myosoft, they use the technique of the segmentation with a thresholding-based object extraction and quantification of fiber size and fiber type. Again, a mouse model was utilized, and they used immunostaining for laminin and myosin heavy chain. Myosoft demonstrated a good efficiency in quantifying and measuring the size of the type 2, type 2B, and type 2X fibers using these immunostainings. The last automatic quantification that I want to present is in automatic and unbiased segmentation and quantification, where the authors also quantified the presence of FAPS progenitor and adipocyte lipid droplets, as well as primary ciliates. In these works, they used the MDX mice control and the MDX mice without cilia. They made an injury that was performed between 10 to 12 weeks at age, and then they leave the muscle TA to regenerate for 21 days before they were harvested. With the semi-automatic erosion function on label to Roy, could improve the cell pose performance, like a level where the fibers are marked manually. And they found that the myofiber, for example, recovered better after cardiotoxin injury compared to glycerol. And this was only possible using this segmentation. Now you can tell me, okay, this is very interesting, but it was mainly developed for a mouse model. And in our routine analysis, the histopathologic diagnosis, what we do a battery of stainings, immunostainings or histoenzymatic reaction. And this multifaceted analysis is the one that establish if there are specific alterations and then orientate and indicate a specific disease or a group of disorder. One trial that has been done by the Japanese group of Ishizo Nishino use a deep convolutional neural network-based algorithm for muscle biopsy diagnosis. What they have done, the authors in this study. So they collected slides from different group of pathology, for example, the idiopathic inflammatory myopathy here, with dermatomyositis, include body myositis, immunomediated necrocytic myopathy, and antisensitizing syndrome, and they confronted using this convolutional neural network applied to the digital scanning to non-myositis muscle disease to see if the machine was superior to the expert in identifying, for example, an idiopathic inflammatory myopathy in contrast with the non-myositis disease. Here you have the algorithm that they develop, how they analyze the images, sorry, and how they did the prediction. What they found is that at least for idiopathic inflammatory myopathies, the machine was superior to the expert, with an accuracy that was 3% higher compared to the physician, which is a little bit upsetting for us, but also tell us that this kind of approaches can really help us in order to refine and implement the definition of our pathologic diagnosis. Globally, what we can do with this digital myopathology associated to the artificial intelligence? Well, we can apply it in order to discriminate different parameters that are fundamental for us in order to decide which is the pathological picture found in a muscle biopsy. That can be, for example, the identification nuclear centralization, the fiber size diameter calculation, the cross-sectional area, the presence of hypertrophic fiber, fibrosis, neurogenic atrophy, ampere contractive fibers, regeneration, or also infiltrates. And these can help us to gain speed and accuracy, especially when we quantify. Currently, when I see a slide, for example, with the TPases of myosin heavy chain, I do a rough estimation of the percentage, but this, of course, is based on my experience and my visual skill, not counting every single fiber. This parameter maybe can be really implemented and ameliorated by this quantitative feature. And then what is important with digital pathology is that we can do telepathology. We can send the images out, have a specific advice by other experts, and as I mentioned before, apply artificial intelligence in order to make a diagnosis or ask the machine to give us some information on specific parameters. Just a little bit of publicity, and I would like to thank all the persons that already participated to this project promoted by the EURO-NMD reference center, where having scanned the H&E stainings of different muscle biopsy, we aim to define through artificial intelligence and digital pathology 4 different patterns of lesion, and based on this, create rapidly a hub where all the center can have access in order to perform, for example, histochemistry or histoenzymology, perform, for example, in dystrophic muscle immunohistochemistry, in inflammatory muscle test different parameters to refine the diagnosis, and where a neurogenic pattern is identified, redress the diagnosis. In the second part of my talk, I would like you to describe a project that we are doing with digital pathology and artificial intelligence on muscle biopsy from calpainopathy patient with limb-girdle muscular dystrophy R1. Why we decided to study specifically the muscle biopsy of this patient? Because this is the most frequent form of limb-girdle muscular dystrophy in Southern European countries. It has a progression that can be really variable, and we do not have a specific antibody that can be used in routine in order to determine the absence of the presence of the protein. And this is particularly limiting the appreciation of the gene therapy approach. This is the gene therapy developed in Geneton by Dr. Isabelle Richard, where through an AAV approach, endovenous approach, they could restore the presence of calpain in the mice KO for the calpain tree after already the dose 2 and very with the efficiency that is very high at dose 3 and dose 4. And also you can see here they restore the parameters, the myopathologic lesion that recover completely after dose 3 in comparison to a wild type. So as these approaches are probably coming, we need to better quantify the lesion of the patient, and then when we will have a therapy, we will probably have an algorithm that can help us to see if there is an histological rescue after a therapeutic approach. Our project that is developed by the PhD student Gianmarco Severa consists in applying and invalidate artificial intelligence-based tool that can quantitatively measure myopathic change found in calpainopathy muscle biopsy. We want to correlate them with the clinical feature and then do a specific correlation of the myopathologic lesion with the muscle MRI findings. The idea is really to identify sensitive myopathologic and imaging outcome measure that can be used for the gene therapy approach, but also for other therapeutic approaches that we hope will arrive soon for this disease. How we are doing this? So we are doing this thanks to a software developed by the group of Daniel Stockholm here in France in Geneton that is called Myosotis. Myosotis combine two elements and two software that are QPath and CellPath, where in QPath, what we have the tissue detection. We perform the tiling, that means to identify different areas of the tissue, and we export this tiling in a specific format. This tiling allows to recognize the areas that are occupied and identified by a specific marker that is represented here by the immunostaining for laminin. But what is lacking is the capacity to recognize the single elements, and this is done by CellPath, that is a software for cellular segmentation that applying a neural network where an image is analyzed through this neural network, recognize the different elements, and in our case is able to recognize the different muscle fiber. This myosotis has been already applied in another muscular dystrophy, specifically in a mouse model of sarcoglycanopathy that was treated with a gene therapy approach. And using myosotis, the colleagues could demonstrate that the myopathologic findings were ameliorating, and for example, for the highest dose of sarcoglycan gene therapy, there was a rescue that was similar to the wild type. So what we did, and I'll show you some preliminary data. First, we selected limb-girdle muscular dystrophy patient and muscle biopsy, and we performed myosotis analysis in order to quantitatively measure myopathic changes. And then we compare and analyze these changes with other autosomal recessive limb-girdle muscular dystrophy in order to see if there is an intervariability. With myosotis, we succeed to identify the two parameters of interest. First of all, in green, you see the area underlying the membrane of the cell, where we have we can have an estimation of the fiber size variability. And then in red, you can see how the system is able to recognize the fibers that harbor internalized or centralized nuclei. And these are preliminary data comparing histologically normal sample that we call here controls to 8 muscle biopsy from limb-girdle muscular dystrophy, R1, calpain related. We found the some different. First of all, we have a fiber diameter that is generally lower in calpainopathies compared to the histologically normal control. And then we have a double distribution with a double peak that correspond to atrophic fibers that are not found in the controls where the distribution is more homogeneous. So the idea is that one first result is that here we have already a quantification of two populations of fibers. We need to know exactly who is who, if these are atrophic fibers, if these are regenerative fibers. These needs to be implemented. But what we see is that the fiber diameter is really reduced in the calpain patient, and there is eventually this second population. What we have done, we then calculated based on the age, the presence of nuclear internalization, that is an indirect marker of muscle regeneration. And for example, in younger patients, we found that the nuclear internalization were less present compared to the calpain patient that are older than 20 years, suggesting that probably these, of course, need to be correlated with the clinical parameter, but there is a kind of progression of the disease. And then when we compare to another limb-girdle muscular dystrophy related to anoctamin, we found that, for example, in calpain 3, there is a lower percentage of nuclear internalization that give us some information about the pathologic process. But of course, these are preliminary data. Another element that we wanted to approach is the fact that we need with our system to recognize the inflammatory infiltrates. We know that in calpainopathies we can have inflammation with macrophages rich regional inflammatory infiltrates, but also we can have infiltrates that are kind of peculiar because they contain eosinophils that you can recognize here by their fuchsinophil staining, like for example here. One of the important question is how the machine can really discriminate between the nuclei and the inflammatory cells. And this can be done by the different density of the nuclei. So what we have done, we tested our controls in compared to a group of inflammatory myopathy. And what we found selecting the areas that are the inflammatory infiltrate, as you can see here in white, we have a signal that allow us to recognize the intensity of the nuclei and be confident that we are analyzing and we are quantifying only the areas that correspond to the inflammatory infiltrate. And here you have a comparison between our controls, between inflammatory myopathy, and you can see effectively that there is more inflammatory infiltrates in the inflammatory, and this has been found by our myosotis approach. Another important element is the presence of eosinophilic. So we asked the machine to tell us if we can recognize this cell. What we have done, we performed a preliminary test using another pathology. This is a slide of a eosinophilic fasciitis, where you have the presence of this fuxinophilic elements with this dotty cytoplasm, and we ask the machine to recognize specifically these areas, these cells, based on the presence of fuxinophilic dotty cytoplasm. And here again, we can see that machine is able to recognize this cell. We will now apply all these algorithm to our series. I show you some preliminary results. Of course, we want to increase the cohort for the quantifying the myopathologic parameters that could be evaluated. And I would like to thank already our collaborators that provided us with AH and he slides or images from limb-girdle muscular dystrophy R1 patient. But let's go and change a little bit of topics, talking about the spatial transcriptomics. In this scheme that I modified from a seminal paper by the group of Ellen Blau in Stanford University, we see what is this technique. This is a powerful technique that allows to to analyze the presence of specific MRA probes that are applied to the section of an animal or in, for example, muscle biopsy. And after doing a sequencing and spatially mapping, we can perform both a cell clustering that allow you to recognize the different type of fibers, or a UMAP clustering where we see the different gene that are expressed in different cells. Just an example among other that was performed by the group of Paolo Spitali in the Netherlands, where the spatial transcriptomic was applied to a model of Duchenne muscular dystrophy. In this paper, the authors show that there is an increased expression of a specific gene, as you can see here, in, for example, areas of muscle regeneration that can be visualized already by the H&E staining. So we really see in tissue what are the genes and where they are expressed. And these give you information on the pathophysiology of a disease. And of course, it's very important in terms of therapeutic rescue after a therapy, and also in therapeutic development, because if we see that, for example, there is an expression of a specific gene, this can be counterbalanced with different pharmacological approach. And they also confirm the findings or the specific lightening of genes in distinct areas thanks to the FISH. That is a technique that shows you the presence of particular RNA inside the cell, and then using a different differentiation dynamic analysis in the MDX D2 muscle, they identify fibers that were predicted to become affected in the future state. And this is particularly interested in terms of trajectory of the disease in terms of possible therapeutic advancement. To finish with my webinar, I would like to mention a little bit a technique that is not new, is the cryo-electron microscopy. This technique has been powered since the 60s, where a transmission electron microscope was put in cryogenic temperature structure, allowing the preservation of the tisular structure. And thanks to the development of high-resolution imaging, we could reveal details, for example, of protein, virus, of cellular components. And there have been a lot of advances recently in sample preparation, analytical algorithms, and these allowed to gain in atomic resolution to see effectively the molecular structure. This technique has been recently applied to the limb-girdle muscular dystrophy R2, that I remember is a form that can manifest both with proximal or with distal muscular dystrophy. This form were previously thought separated entities, and now we know that are part of the same spectrum. And in this patient, what we have a dystrophic pattern that is due by the lacking of the membrane protein, that is the dysferlin, that is contained both at level of the membrane and the T-tubules, and that is particularly important in the muscle repair. The authors of this very interesting paper could resolute the structure of the monomer of dysferlin that you can see here appearing in this image. And they also defined the different domain, and they could identify what are the structure and their interaction inside the molecule of dysferlin. And thanks to this, they also developed a possible proposed dynamic of the membrane repair that is performed by the dysferlin. So the author in this scheme showed that through a membrane damage, we have the entering of calcium, and thanks to this chemical signal, the dysferlin the monomer of dysferlin can be brought up to the surface by vesicle. They can dimerize following to oligomerization, and then thanks to the interaction of the different domain, make like a band-aid a reparation of the membrane. This fine and refined dissection of the mechanism has been gained with an imaging technique from muscle tissue, and show you how this dynamic happens and how this mechanism can be of interest in the term in the future development, for example, of therapeutic strategy. So to sum up a little bit, what we have today is that diagnostic myopathology is progressive toward a complete digitalization. We already have partially here in our center. In other center, they are doing for all the muscle biopsy. We will have probably an automatization of the analysis with the assistance of artificial intelligence. And this is a promising tool because can help us in determine different patterns, can help us in quantify specific lesion, and also give like a prognostic, have a prognostic value to tell how high, how severe is the pathologic process. And then I show you with different example with the spatial transcriptomic, but also these different software that help you quantify how the research in myopathology with artificial intelligence is important to dissect the disease pathomechanism. How do I see, do I think that the future evolution of the myopathology will be? Well, I think that thanks to our intelligence and thanks to the artificial intelligence, we will have the possibility to really appreciate from the tissue exactly the composition in gene, in different altered pathways, in order to specifically develop a pharmacological approach that could help our patient to ameliorate their disease. And with this, I end my webinar. I thank you very much for your attention, and I wish you Merry Christmas and happy 2025, as this is the last webinar of the year. Thank you very much.
Thank you very much, Edoardo. It was a fantastic webinar. So if anyone have a question for Professor Malfatti, please raise your hand or put the question into the chat box.
Don't be shy.
Maybe it was clear for everyone. I think we will close the webinar. Professor Malfatti, thank you very much.
Thank you very
For your
much.
presence today, and happy holiday.
Bye bye. Thank you very much.
Bye. Thank you. Bye.